Okay, so we'll introduce our next speaker, Prof. Sharmila Dorbala. She's the Director of Cardiology at Brigham and Women Hospital and Professor of Radiology at Harvard Medical School. Her research is focused on molecular imaging of cardiac amyloidosis and serves as a principal investigator for several clinical research studies in cardiac amyloidosis. She's the past president of the American Society of Nuclear Cardiology and the Cardiovascular Council of the SNNMI. She's also a friend of the country and continent, and last year she hosted the first African workshop on cardiac amyloidosis and a full week of registrar teaching. Prof. Dorbala, much appreciated. The podium is yours.
Thank you very much, Dr. Mazaka and Dr. Wangu and the entire SASNM 2023. Really happy to be here and share with you some comments about cardiac amyloidosis. So these are my disclosures. So what are amyloidosis? So these are a large group of disorders which are biochemically distinct, but these are caused by misfolded proteins forming fibrils which deposit in various organs, causing organ dysfunction. Cardiac amyloidosis typically presents with heart failure, but other complications of atrial fibrillation, thrombosis, and microvascular dysfunction, angina in the absence of obstructive coronary disease, claudication are all also seen. So the big question for all of us is, why are we talking about this disease, which is a rare disease, which has been underdiagnosed, and why are we talking about this disease at a Nuclear Medicine Congress in 2023? So in my mind, there are a few reasons why this has risen to prominence. One is this disease has a very distinct pathophysiology, but extremely high mortality. As you can see with AL amyloidosis, the median survival, even with treatment, as you can see here, is less than 2 years. Without treatment, median survival is only 6 months. With ATTR amyloidosis, the median survival is approximately 3 years, and of course this is without treatment. So it's a highly fatal disease. More importantly, this disease can now be treated. So we have extremely effective therapies for AL amyloidosis. Daratumumab is a monoclonal antibody against the plasma cells, and this appears to be highly effective. And this study shows that patients on daratumumab tend to have much better outcome compared to the control group treated with chemotherapy that did not include daratumumab. Likewise, for the first time, we also have now treatments for the transthyretin form of disease, and tafamidis is the only approved therapy, but this stabilizes the disease and improves outcomes. So this disease, which we thought was rare, which we thought was uncurable, and was inevitably leading to death, now can be treated if it can be diagnosed. So the big reason is there's also now antibody therapies to remove the amyloid fibril. You know that this has been going on for a long time to look at antibodies for Alzheimer's disease, but here's antibodies to remove amyloid from the heart, and there is some exciting data suggesting that these are well tolerated and potentially may be helpful to remove the amyloid. So for all these reasons, this rare disease can now be diagnosed and treated. So it becomes really imperative upon us that we need to help the clinicians diagnose this condition. And most importantly, we are all hearing about it because there are nuclear medicine techniques to make this diagnosis without need for biopsy. So that's what we'll talk about. So a little background. So there are two common types of amyloidosis. One is called AL amyloidosis and the other is called ATTR amyloidosis. And there are many rare forms of disease. So AL amyloidosis is a plasma cell dyscrasia. It's a bone marrow disease. These plasma cells produce excess immunoglobulin light chains that form fibrils. They deposit in the heart, kidney, and musculoskeletal system. Transthyretin amyloidosis results from misfolding of transthyretin protein. It is exactly as it sounds. It's a transport protein that transports thyroxine and retinol, transthyretin. It's a normal protein produced by the liver in all of us. For some reason, with aging, this protein misfolds, form fibrils, and causes dysfunction. In some patients, there's a hereditary component, there's a mutation in the TTR gene, and the 4 components of the transthyretin protein are not similar, and that leads to misfolding and the hereditary form of disease, which has very similar manifestations, but at a younger age. So who do you test for amyloidosis? Patients who have symptoms that are heart failure with preserved ejection fraction, gene positive, older adults, those who have low flow, low gradient aortic stenosis, carpal tunnel syndrome, biceps tendon rupture, lumbar spinal stenosis. And for some reason, these patients with heart failure develop intolerance to heart failure medications. So if you have a patient on heart failure who's tolerating all the meds, now suddenly you start seeing intolerance, consider amyloid. Echocardiographic features and MRI features are increased wall thickness, diastolic dysfunction, reduced global longitudinal strain, and many other abnormalities. With MRI specifically, you can look at a very classical pattern of diffuse late gadolinium enhancement and expanded extracellular volume. Typically, the ECV is more than 40%, which is very, very high. How do you diagnose this? Of course, you can diagnose this histologically. You just put a catheter into the right side of the heart, take some biopsies on the interventricular septum from the right side, and then you can send it off for typing, and you can make a definitive diagnosis of AL, ATTR, or rare forms. You can also make a diagnosis by extracardiac biopsy. With extracardiac biopsy, it can be a fat pad, or it can be kidney or involved organ biopsy. Then you know the type of amyloid from that. But in a patient with systemic biopsy of AL, if there's abnormal cardiac biomarkers, that is sufficient to diagnose AL amyloidosis. With AL, ATTR, or rare forms diagnosed by peripheral biopsy, then typical cardiac imaging features will make for a non-invasive diagnosis on top of extracardiac biopsy. Transthyretin form of disease can be diagnosed without biopsy, and here you have a patient who has typical imaging features. You exclude a plasma cell dyscrasia, and then if you have technetium 99M labeled PYP, DPD, or HDP scanning, which is grade 2 or grade 3. Grade 2 is myocardial uptake equal to rib uptake, and grade 3 is myocardial uptake greater than rib. So basically, in this scenario, you do not need biopsy. You can make a non-invasive diagnosis, and you can treat this patient. So let me just share 2 cases with you. First one is a 74-year-old male with new onset heart failure, progressive osteoarthritis, and he was referred for total knee replacement. And he also has a past medical history of bilateral carpal tunnel syndrome 10 years and 8 years ago, and he does not have any biceps tendon rupture. Here's his echocardiogram. Hope they will move. And then you can see the ventricle is very thickened, and you can see the right ventricle is also thickened when the other image moves. You can see the right ventricle. So biventricular thickening, biatrial enlargement, very classical appearance, and reduced global longitudinal strain, severe reduction with sparing of the apical. So this portion contracts better than the mid and the base, a very classical image for cardiac amyloidosis. Patient underwent a cardiac MRI, and you can see all echocardiographic features are confirmed on MRI. In addition, you can look at myocardial characteristics, diffuse transmural late gadolinium enhancement, and extracellular volume, which is more than 0.41. So together with the history of the carpal tunnel syndrome, knee problems, HFpEF, classical echo, classical MRI, in a 73-year-old man, the story is very compelling for possible cardiac amyloidosis. So he was referred to us, laboratory evaluation was performed, NT-proBNP and troponin T were abnormal. He had evaluation for light chain amyloidosis, and a plasma cell dyscrasia was excluded, got a fat pad biopsy which was negative. At this point, he was referred for PYP imaging because wild-type transthyretin amyloidosis was suspected, and we performed PYP imaging with SPECT-CT. The CT component is extremely important. So here you can look at myocardial uptake, which is greater than rib uptake. There's no blood pool activity in the center, and here's the SPECT without the CT. And once you see this, you've already excluded AL amyloid. This test is highly specific and makes a diagnosis of transthyretin amyloid. We know that based on this multi-center study, which showed that in the patient that I described in the classic scenario with typical imaging features, no AL amyloid, this test is nearly 100% specific for making a diagnosis of transthyretin amyloid, but the sensitivity is only 70%. So in this study, they looked at endomyocardial biopsy correlation and showed this. Based on this, the patient was diagnosed with ATTR cardiac amyloidosis. A genetic test is routinely performed on all patients where the PYP is positive to make sure that this is not an inherited form of disease, and that was negative. Patient was treated with tafamidis. So modern trends, this diagnosis was previously made by endomyocardial biopsy, and now we see that PYP imaging is replacing endomyocardial biopsy. Data from the THEOS registry of nearly 1,000 patients. This is a global longitudinal observational survey, and what you see here in blue is tissue biopsy, which is declining, and in orange is scintigraphic diagnosis, and that is taking over and replacing biopsy. What this has done is we now have the ability to screen high-risk patients for TTR cardiac amyloid. Therefore, we are able to better define the epidemiology of this disease. Previously, we needed endomyocardial biopsy, and that limited us significantly. Now, with non-invasive diagnosis, we know that among patients with heart failure with preserved ejection fraction who are hospitalized, 13% have coexistent amyloidosis. Aortic stenosis surgical, 6%. TAVR patients who are referred for severe AS with TAVR, 16.6%. Community-based studies with HFpEF have shown a much lower prevalence, 10% in males and about 2.2% in women. Carpal tunnel surgery, different studies have reported different numbers, but approximately 8% of the patients who undergone surgery for carpal tunnel syndrome also have coexistent amyloid in the heart. Quantitation is now emerging as the next frontier in this disease. SUV-based quantitation using SPECT-CT metrics is extremely important because this helps us go one step forward. Not only do we say the scan is positive or negative, but we may be able to quantify the amount of amyloid and use this information to make an early diagnosis, assess response to therapy, and maybe stratify risk. So this was a study from Professor Hacker's group who looked at patients who received tafamidis therapy and who underwent DPD scanning before and after tafamidis, 7 months after tafamidis. And what they found was that when they categorized the patients into responders and non-responders based on a DPD retention index, they showed that the responders seemed to have a slightly better improvement in LV ejection fraction and improvement in RV ejection fraction on cardiac MRI compared to the non-responders. When you looked at the overall cohort, there was no significant change. Again, suggesting that radionuclide method may help us detect early changes before you see overt changes in molecular imaging. So the next case I wanted to share with you is an 82-year-old woman with dyspnea, abnormal cardiac biomarkers, abnormal plasma cell dyscrasia evaluation. So fat pad biopsy was performed, confirmed that the patient had AL amyloidosis. Echocardiography is very classical in this patient. AL cardiac amyloidosis is diagnosed. Why? Because you have a systemic biopsy, typical cardiac imaging features, and abnormal cardiac biomarkers. So this makes for a diagnosis of AL amyloidosis. Patient went into a research study with us with F18 floor beta PET. As you all know, this is a tracer approved for imaging amyloid in the brain. A number of sites have now used it for cardiac imaging, and here you can see beautiful imaging. So the value of PET imaging in amyloid is that PYP, DPD, HTP are unreliable to diagnose AL amyloidosis. They're insensitive for this disease. Therefore, we have currently no approved radiotracers to image AL amyloid. So these PET radiotracers are going to have a huge role because they can allow us to diagnose AL amyloid for the first time using radiotracers. Here's an example of a patient with a typical echo. PYP is equivocal. So what do you do in this case? Because the patient's symptoms were very classical, MRI was performed, and that also was very classical. So at this point, we sent him for biopsy. Endomyocardial biopsy confirmed cardiac amyloidosis. And then patient went into a research study, and he received a new PET scan with I-124 labeled tracer called evusamitide. And again, you can see beautiful images. So equivocal P/P SPECT, you can see the PET imaging really helps in making a diagnosis. The PET tracers are also helpful for making diagnosis of rare forms of amyloid, because PYP-DPD don't really consistently show rare forms of amyloid. So there may be growing applications for PET tracers. These PET tracers are known to bind to the beta-pleated sheet structure. Therefore, they are independent of the precursor protein. Doesn't matter what precursor protein, but they bind to the beta-pleated sheet structure. And the evusamitide compound binds to electronegative surfaces on glycosaminoglycans and amyloid fibrils. Bottom line is the PET tracers target the amyloid fibril directly. The other advantage of this tracer is they can give us whole body amyloid imaging, not just the heart, but you can look at the liver, you can look at the spleen, and kidneys in some cases. And again, heart in AL, rare forms of disease, and in ATTR as well. Here's how a negative scan would look like, completely negative. Amyloid PET tracers are retained more in the heart of patients with amyloidosis compared to controls. And you have data from multiple institutions showing the same thing. Patients with amyloidosis have much higher retention of the tracer compared to control patients who have a much lower. So this is a growing area of interest and study in the field, and further evaluation is necessary. So I just want to end with an algorithm for study of this disease. So if you're suspecting a patient to have amyloidosis, patient has heart failure, who has clinical or imaging red flags, the first step is to make sure this is not AL amyloid. So you send off serum free light chain studies, serum and urine immunofixation electrophoresis to exclude a plasma cell dyscrasia. Why is that? Because if untreated, AL amyloidosis has a median survival of less than 12 months. So the patient is dead if you have delays in treatment or diagnosis. So once you make sure it's not that, if that's normal, then you go ahead with bone avid tracer scintigraphy. If that's positive, you send off a genetic test and you classify wild type or variant. If the bone avid tracer scintigraphy is negative, it's likely that the patient does not have cardiac amyloidosis and you're done. If it's grade 1, it's an equivocal study. In those cases, further imaging with MRI or biopsy, and then you can proceed. Rare cases where the P/P scan is grade 0, it can still be AL, it can still be some forms of hereditary or wild-type disease, as the case I showed you. In those cases, with high suspicion, you may consider further evaluation with MRI and or biopsy. Of course, if your free light chain studies are abnormal, then you straight away refer the patient to a hematologist. Biopsy is typically necessary in this case, and then amyloidosis is excluded or AL cardiac amyloidosis is identified. Just one refinement to this protocol made recently was that in patients who are older adults, MGUS, monoclonal gammopathy of uncertain significance, is quite common. Renal dysfunction is also quite common, and you may see isolated abnormalities in free light chains, which do not represent plasma cell dyscrasia, but it just represents renal dysfunction. So because of that, we now have new EGFR-adjusted free light chain ratios, so you can apply that, and if those are normal, then you can send these patients for PYP-DPD. If these are abnormal after you apply the renally adjusted doses, then they go down the pathway of hematologist referral and biopsy in that case. So with that, I want to thank you very much for your attention, and I do want to make a plug for the INCAPS-4 study. I know that Dr. Wangu, Dr. Sategi, and others here are involved in this study. This is a worldwide cross-sectional study which will be conducted during October and November of 2023, looking at SPECT and PET myocardial perfusion imaging, calcium score, and CT-based coronary angiography. Sites, in order to participate in this study, need to perform one of these tests, either CT, SPECT, or PET. And all that's required for this study is to provide retrospective data from 1 week from your lab practice. And aiming for an IRB waiver because it's not human subjects research, and partnering with professional societies. And the first 1,000 labs which participate in the study will receive a nominal 100 euros for participation, and they're national coordinators for each country. So if you're interested, please reach out to Professor Wangu, Professor Sategi, or to Professor Andrew Einstein at Columbia, who's listed out there. So let me stop there and happy to take any questions.